Good morning, friends. Today we'll discuss a case of aortic rupture during PTA in a case of aortoarteritis. It's a rare complication and how to manage it. And in the we'll discuss the review of literature of aortoarteritis too. So this is the 2022 American College of Rheumatology classification for Takayasu's arthritis, and absolute criteria are age less than 60 and evidence of vasculitis on imaging. There are additional criteria and points are given according to it, and more than 5 points classify as Takayasu's arthritis. Now, there are foundation definitions for this: suspected disease, active disease, severe disease, and non-severe disease, remission, refractory disease, relapse, and cranial ischemia. And the treatment are IV glucocorticoids, high dose glucocorticoids, maintenance dose glucocorticoids, low dose glucocorticoids, and disease modifying treatment and immunologic therapy, and surgical intervention when they are required. So our patient, she was female, 46 years. She was a known case of aortoarteritis, Takayasu's aortoarteritis, underwent intervention to renal and mesenteric artery in 2008. She was in remission since then and on was low-dose glucocorticoids in consult with rheumatologists, and with mycophenolate and prednisolone going on quiescent course in remissions for the last about 16-17 years. Now recently she had aggravation of symptoms since 1 month, fever, fatigue, joint pains, claudication of both limbs. Investigation revealed high CRP. Doppler was suggestive of 90% lesion in infrarenal abdominal aorta, which was not present in the previous 2008 angio. There was only minor plaques. CTE angio confirmed the above findings. Renal and mesenteric were 50-60% lesions and not significant hemodynamically. She was put on pulse methylprednisolone therapy, after which the CRP refused to come down. She had fever and fatigue, and so additionally rituximab was added by the rheumatologist. Still 1 month over, she had no relief in symptoms and claudication was aggravated, and there was rest pain. She had night pains which led her sleep to be disturbed. She had severe hypertension in both upper limbs, and lower limb pulses were not palpable. CRP had decreased from about 230 to about 90, but it was still high. A repeat Doppler showed occlusion, oblique 90% lesion in infrarenal aorta. Steroids were increased. In view of persistent symptoms, a planned intervention was done in consult with rheumatologists. This is repeat CT angio done, which showed a total occlusion of 2.5 centimeter in abdominal aorta. SMA and celiac were deceased, but not significant. So now overview of treatment recommendation. The recommendations are based on clinical and radiographic assessments. Active Takayasu's arthritis not on immunosuppression therapy. The first thing is to increase therapy and add immunosuppressions. If not recurring, add biologic things. The guidelines are very sure that surgical intervention should come last. Vascular changes identified on imaging studies. And if patient is symptomatic, you have to go for increasing dose of this immunosuppressions and steroids. However, even after this, we have to, it does not respond, then we have to consider surgical therapy. So in consultation with the rheumatologist, uh, surgical intervention was planned in form of PTA to the abdominal aorta. So we took both the femoral and a left brachial access, integrate shoot from femoral root sword, total occlusion of distal abdominal aorta above the bifurcation. A shoot from the radial showed that it was infrarenal total occlusion and probably thrombus was there. Next. We crossed wire from the femoral root quite easily and confirmed that it was in right channel. Then we started inflating with a 639 balloon. Then the post dilatation, the gradient was more than 40 mmHg. We kept the Tiger catheter at the renal artery so that we do not compress the renal artery during balloon inflations. The gradient was more than 40. So we upgraded to 8 millimeter balloon, then to 10 millimeter balloon, and then to 12 millimeter balloon. Serial inflations were given. With 6 and 8 millimeter balloon, we went at high atmosphere up to 14, 16 atmosphere. With 10, 12, we were slightly vary and we went up only up to 6 millimeter. However, after 12 millimeter balloon also, there was inadequate flow and almost again total occlusion was there, probably a flap or so. And the gradient between the femoral and femoral seat, we had taken about 8 French seat so that we could get pressure despite the wire being across or catheter being across. So gradient across the lesion was more than 14 millimeter. We reviewed the CT again. The aortic size was more than 14. So we took a 14 millimeter balloon and inflated at 1 atmosphere. After 14 millimeter balloon, when we took angio, it was a free rupture into the pericardium. So we gave prolonged inflation at 1 atmosphere for about 15 minutes. We measured the renals when we kept it infrarenal. Next. However, there was no sealing after prolonged balloon inflation run, and immediate on deflation of balloon, there was severe hypotension. So we kept it inflated. So we took a shoot because lower and in angio guidance we took opposite femoral access. Now then we passed a wire from the opposite side, deflated the balloon for a second, and then immediately pushed the balloon up because we got very less time. During this we did cross match and started one PCV. Then we confirmed the crossing and we put up 10 by 39 balloon expandable graft stent from the other side. This exchange had to be very rapid because there was lots of fall in blood pressure during that time. We inflated a 10 by 39 balloon expandable graft stent from the opposite side. We kept the wire and catheter from on the other side for access. Then serial dilatation with 12 and 14 atmosphere balloon were done. The company recommends dilatation of this balloon expandable graft stent up to 12 millimeter only. But as we had already expanded this to 14 millimeter and we had no 14 millimeter stent, we expanded this with 14 millimeter at 1. There was still persistent slight leak after 14 atmosphere. We removed the jailed wire. Then, and here we were contemplating whether we should give it for surgery or not. However, the surgeons were not very ready to take this patient up. Limited options they had there just to put a interposition graft. But so what we said that we could give with a balloon inflated, prolonged, but still we tried. So we inflated the balloon every 15 minutes and then we checked. We gave prolonged inflation for 15 minutes and then we checked after every 15 minutes. Now the pressure was, patient was holding on to the pressure. And we passed a pigtail from the other side. Run. And the leakage had stopped significantly. So after about 2 hours, the abdominal leakage had stopped. Patient was hemodynamically stable. This was the final DSA, which showed slight flap above the stent, but no extravasation, and the gradient across the abdominal aorta was less than 10 millimeter mercury on both sides. We kept the patient on table for about 1 hour, and then with stable hemodynamics shifted her to the ICU. Patient had stormy in-hospital course. As the guidelines recommend with active disease, whenever we are doing intervention, we have to give an IV methylprednisolone prior to the surgery. So we had already given IV methylprednisolone. Patient had fall in HB up to 7 gram percentage, and so we required 3 units of PC. Total count increase on day 1 and 2 up to 40,000 per cubic millimeter. There was persistent fever for first 3 days. Steroid we had withhold for the first 3 days in view of rising count and high CRP. However, we were slightly on the comfort level because PCT was less than 2.5. Daily USG, AG, girth, urine output and RFT monitoring was done. IV antibiotics were started, and patient started settling on day 4 onwards. Single antiplatelet was started on day 3. First 3 days we had not started any antiplatelets. There was no fall in HB after starting single antiplatelet. Steroids started on discharge day 6. CT abdomen and angio was done prior to discharge. The post-op CT angio revealed extensive retroperitoneal hematoma around IVC posterior part of third duodenum. IVC showed minor thrombus, but however patient had no swelling. Aorta showed normal patency of instant lumen. Stent in proximal superior mesenteric artery showed normal patency lumen. There were multiple infarcts in right renal parenchyma. However, RFTs were normal and left kidney was normal, so we did not do anything. And the lucky part was there was no extravasation. So we reviewed the literature, and we got one from Indian Heart Journal published in 2014 and showed the aortic rupture during aortoplasty in Takayasu's arthritis. They reported about 13 cases, 10 of which were in coarctation of aorta, and 3 were in Takayasu's arthritis. There was the 4th case was theirs, and out of this 4, 2 had died and 2 were surviving. So the mortality of such cases is about 50%, and it is a very high risk. This patch aortoplasty, both patients who underwent surgery had died. However, aortic stenting with stent graft was saved by Dr. Tyagi et al. This case also they had used a covered stent to treat this. So probably a covered stent would be a better option than surgery in such cases. Second thing, the discrepancy between coarctation of aorta and Takayasu's arthritis. It is said that Takayasu's arthritis involves all the three layers and it is very steep. So it requires high atmosphere balloon for dilatation. However, the chances of rupture are less. But whenever rupture occurs, it is disastrous. In coarctation of aorta, because it is an aortopathy and medial layer is weaker, the chances of rupture are more than in aortoarteritis. So take home messages from this: rupture in aortoarteritis, aortoplasty is rare but very high mortality. Avoid doing interventions unless absolutely necessary. Always better when disease activity is low. However, if patient is persistently symptomatic and the disease is progressing from 90% lesion to total occlusion and patient is symptomatic, the limb is threatened, then probably we have to go for intervention. Pulse steroids on the day of interventions, as IV pulse steroids have to be given on the day of interventions. Double access is always preferred. Anticipate problems, and both femoral arteries, if cannulated, it is better. We had cannulated only one femoral and one brachial, and the second artery was taken later on. Appropriate sites, graft stents on board, always necessary. We had the unfortunate event that we had only graft stents available up to 10 millimeters. Anticipate all risk and explain the patient beforehand, which we had done. Thank you.